There we go. I guess the recording started, so I'll start again. So Professor Ciska Heida is an associate professor in the Biomedical Signals and Systems Group at the University of Twente in the Netherlands. She has a background in electrical engineering and received her PhD in the field of neurotechnology, also at the University of Twente. Her graduate research activities focus on the use of dielectrophoretic forces to trap neuronal cells to create a cultured neuron probe that can be used to selectively stimulate nerves by electrical signals for the restoration of function. Her current research interests focus on increasing our understanding of the central mechanisms of human motor control and the pathophysiology underlying movement disorders, and also on the application of neuromodulation techniques for restoring motor function. And today she will deliver a talk entitled Computational Models to Study the Parkinsonian Brain and the Mechanisms of Neurostimulation. We look forward to it. Take it away, Ciska.
Thanks, Luca, for the introduction. And yeah, welcome and good afternoon. Yeah, I've been visiting the group of Professor Hutchinson for 2 years in a row now, and it's been really pleasant to work with the Toronto Western Hospital on several studies. And yeah, unfortunately, this or last year, it was just not possible to visit, but it's nice to at least visit you in this virtual way today. Yeah, so thanks for the invitation. And yeah, I will focus on modeling. I was asked to give a presentation on our modeling studies. So I will focus on 2 different types of modeling. One is volume conduction modeling, and then I will present some of our work on motor cortex stimulation and also on STN stimulation, so deep brain stimulation. And I also will focus on the neuronal network modeling that we have done in the past and still are working on. And that's more related to the symptoms of Parkinson's disease, bradykinesia, and the Parkinsonian tremor. And I will finish with some future studies. But first, to give you a short introduction of our group. Yeah, I'm located in Enschede, that's in the Netherlands, so the University of Twente. And yeah, my research focus is central motor control. So we're trying to get more insight into the mechanisms of central motor control in the normal healthy system, but also in the diseased system. So yeah, Parkinson's disease is the main focus in our research, but also we have included patients with essential tremor, for example, to also make the comparison between Parkinson's disease and essential tremor, since they have similar symptoms. And in addition, yeah, we're developing novel and also optimizing existing therapeutic methods. So from origin, our university is a technical university. So our research is mainly technology driven. So we're focusing on the technology that's been used in helping patients. So in this case, we look into deep brain stimulation for Parkinson's disease. So we're looking into optimizing stimulation. So you see a number of different electrodes that are used or have been designed for deep brain stimulation. So I will also come back to that. We have done some modeling studies in determining the local effects of stimulation by using these types of electrodes. And we're also developing new tools to, for example, measure the movements that are performed by patients. So this is an example of the power glove that we have recently developed. It's not yet a real glove, but the idea is to be able to measure using inertial sensors positioned at each segment of the finger, to be able to record hand movements and finger movements in a very accurate way. So hopefully with testing, for example, deep brain stimulation settings, we can identify the subtle differences in the stimulation settings and responses. So we're looking into the mechanisms of deep brain stimulation, optimizing deep brain stimulation. So steering the field, that's what we've been looking into, but also the personalization. So recently, of course, many groups are working on a closed loop system or more adaptive control of the stimulation. We're also looking into cueing. So freezing or gait is also one of the symptoms that we're looking into. And usually this is a group of patients that does not make use of deep brain stimulation so much. But cueing is sometimes quite helpful in these patients. So in this short video, you see a patient walking on a floor at which, yes, thin stripes or broader bars are located. And so the cueing consists of patterns like the zebra crossing patterns. It can also be an auditory pattern. So a metronome pattern can also be very helpful for these patients to walk better. So also in this case, well, what's the mechanism of freezing? And also what's the mechanism of this type of therapy to make these patients walk better or overcome their freezing periods?
So can I ask a quick question?
Yeah, sure.
So this is the same patient with no intervention, and literally the only thing that's changed is the thickness of the bars, and that's what's affecting his ability to walk?
Yeah, indeed. Yeah.
Wow.
Yeah, so it's a question mark, of course. What's the mechanism of this cueing? So there are quite a number of hypotheses. One of them is that it's helping to determine the distances. So scaling of the movement, but also the timing of the movement. So the auditory cues could focus a bit more on the timing of the movements and helping them, maybe helping them to overcome the defective pathways or the functionality of the defective pathways in the brain. So that's also one of the hypotheses, that maybe a different parallel pathway is excited when seeing or hearing these patterns, so that the freezing is overcome.
Is this something that is seen sort of throughout the duration of Parkinson's, or will this feature of the cueing helping the patient sort of degrade as the disease progresses?
Yeah, it's mostly that if patients make a lot of use of the cueing, that it doesn't, or it loses its effectiveness a bit. And of course, the disease is progressing, so the effectiveness will also decrease. But that's what we're still trying to find out. Also, we would like to provide this type of cueing in a non-stationary way. So one of the examples is shown here. If we can make use, for example, of the HoloLens, so providing these patterns using augmented reality, then we could help those patients. And also in this case, we're looking for on-demand application of cueing, so only when it's needed, so to make sure also that there's no degrading effect over time if you use it too much. But it's a question, of course, what type of cues to use. So would it be auditory or visual, which would be most beneficial for a particular patient? As you can see here, the thickness or the height of the bars is quite crucial in being effective or not.
That's fascinating. Cool, thank you.
Yeah, you're welcome. Yeah, so you're free to ask any questions whenever you like. So this is just to give you a short overview of what we do in the Central Motor Control Research team. We're collaborating with quite a number of groups, clinical groups, but also a number of companies. Just a short introduction of the basal ganglia and the dysfunction of the basal ganglia with regard to Parkinson's disease, since that's the basis for our modeling study. So on the right you see the scheme of the basal ganglia with the number of connections indicated. Probably it's not a complete network scheme, but it's what we use mainly. And the problems in Parkinson's disease, of course, are related to the degeneration in the substantia nigra. And what we see is that the normal activity patterns, which are quite irregular, so quite irregular spiking of the different neurons in these nuclei, and that changes with regard to Parkinson's disease. So because of the loss of dopamine, this pattern changes into a more bursting pattern. And we can also see that the different frequency bands that are usually appearing in those spiking patterns are partly disappearing. So especially the higher frequency components have been lost in Parkinson's patients, and those are related to the prokinetic function. So especially motor control requires those higher frequencies. And the lower frequencies have been enhanced. So the akinetic frequency components are enhanced. So resulting then in the bradykinetic, akinetic symptoms of the disease. So it's an imbalance within the network. So there are multiple pathways. There's the hyperdirect pathway from cortex to the STN. There's the direct pathway from the cortex to the striatum directly to the output nucleus, the GPI of the basal ganglia. And there's also the indirect pathway from striatum through the GBE, the globus pallidus, the external part of it, the STN, and then to the output nucleus. So the idea of Parkinson's disease is that there's an imbalance between the two pathways. So the direct pathway which should facilitate movement is blocked because of the increased activity in the GPI. So the thalamus cannot be disinhibited so much anymore. So it's not allowing movements to be performed. And the indirect pathway has increased in activity. So it's not only an imbalance in the pathways and increase or decrease of activity in more average firing patterns, it's also a difference in the pattern itself. So it's become a more bursting pattern, and especially also the tremor frequency can be quite significant in these nuclei. So there's also an oscillatory pattern. So multiple nuclei start to show the same activity patterns. And if we look at deep brain stimulation, then still I think the leading hypothesis on the mechanism of deep brain stimulation is that it's desynchronizing these oscillatory patterns in the basal ganglia nuclei. So now to start with our modeling studies, I will start with the volume conduction modeling. And one of the models that we have set up is motor cortex stimulation, or to look at motor cortex stimulation. The idea was risen because of a paper from McGill in which motor cortex stimulation was used to detect the motor area within the STN. So the idea was to, if we could make use of such a method, so applying cortical stimulation and measuring in the STN to detect the motor area, we could more optimally maybe target DBS in the motor area of the STN. So in the paper of McGill, you can find the response to this cortical stimulation, and it can be related to the different pathways. So the increase in STN activity, neuronal activity, is related to the direct activation through the hyperdirect pathway, and you can also see the transportation of activation through the network through the indirect pathway. But this then helped us to create the we came to the conclusion that it might be really interesting to look at which axons are actually activated in motor cortex stimulation if we also look at the application of motor cortex stimulation for Parkinson's disease. So this is completely based on studies that we found in literature. So we made use of the outcomes of different stimulation settings, different configurations. And the overall clinical result was that the three main symptoms, like akinesia, rigidity, and tremor, could be relieved by the use of motor cortex stimulation, but the results varied widely. And this probably has to do with a lot of differences in the setup of these stimulations settings. So stimulation parameters were quite different for the different studies, but also the electrode configurations used, and also the distances between the electrodes, and also the diameters of the electrodes used. So is cathodal, anodal, or bipolar stimulation used? And also the exact location of the electrode is, of course, of relevance. So the proposed neuronal populations are indicated here. So it could be the pyramidal tract, so PT-type cells. It could also be the intratelencephalic type of pyramidal cells, but it could also be the basket cells. So these are the three types that, are the most probable axonal populations that are activating the motor cortex stimulation. And each have their different connections with the basal ganglia, so the hyperdirect pathway or the direct and indirect pathway, and the basket cells have an inhibitory effect on the pyramidal nerve, so you have a modulatory influence on all of the pathways. So the aim of this modeling study was to look at the different clinical studies and to look at the effective mechanisms of motor cortex stimulation. And once we know which axonal populations to target, we can, of course, then also try to come up with different or optimized protocols to very selectively target these populations. So we started with a very simple head model and included then part of the brain, so part of the cortex in this case, so the gyrus and the sulci are only included for a small part of the brain. And we have simplified the head model into a box in which this small internal box is located, in which we have applied all the details of the different layers and also the details of the gyrus and the sulci. So the axon models were included quite in a simple cable model way. So different basket cells were included in the different layers and also with different diameters. The IT-type axons and also the PT-type axons were included, and also including their different diameters. So all data is retrieved from other studies, and we made use of human data as most as far as we could find it.
Ciska, could I ask you a question? Sorry.
Yes, sure.
For the IT type axons, you mentioned that they're like direct pathway and indirect pathway axons. Are they striatal to cortex? Like what are they? Where's the source and origin, I suppose, at least?
Yeah, good questions. I'm not really sure where they are located, but in parallel, I guess they're connected to the striatum.
Okay.
So directly influencing the two different pathways. But we haven't looked that much into the details of the connections actually to the basal ganglia. We just know that from previous studies, they are or should be connected to these different pathways. And so the main focus here is on the different axons that we have included in the modeling. But indeed, it's interesting to look into the details of the different actual connections. Yeah, does that answer your question?
Yeah, thank you.
Yeah. So the pyramidal axons, we have included also the collaterals in these axons, and two different types were included depending on the direction of these collaterals in relation to the gyrus. So we tested different stimulation protocols. So, and then we tested for each individual axon whether or not it was activated. So we looked for the activation thresholds for each individual axon, and also we looked at the activation fraction. So how many of each type was activated for the different types of stimulation. So yeah, to give a short overview of the results, these are the basket cells axons. So it looks like they're on top of the gyrus, but actually these are the layer 3 basket axons. So you can see the 2 electrodes. In one case, it's a cathodal stimulation with the with the reference located at a faraway position, more or less. And in the other case, you see bipolar stimulation. So there's an anode and a cathode. And quite similarly, the activation patterns are found for the basket cells. So you can see the different threshold levels. And yeah, in the anode cathode, the bipolar stimulation configuration, you can see that it's quite similar to the cathode stimulations configuration. And that's what we've often seen, that the distance between anode and cathode is quite large. So actually it's like a monopolar stimulation configuration as well. So the patterns are quite symmetrical, not completely symmetrical because of the location of the reference. And if we look at the different types of axons, then yeah, these are the results for the cathodal stimulation and bipolar stimulation for just one configuration of the electrodes, locations and dimensions. But as you can see, that mostly the basket axons are activated. So at layer 3, of course, they are most easily activated because of the higher location compared to the location of the electrodes, but also the layer 5 basket axons can be activated quite well in comparison to the other types of axons. So it's quite probable that the clinical effective mechanism is related to the activation of the basket cells. And especially the IT type of pyramidal axons were hardly activated. So it's not that likely that these axons are involved in the clinical beneficial effects.
Sorry, could I ask a quick question, Ciska?
Yeah, sure.
Yeah, so in terms of the cell numbers, like, so presumably there's a lot less basket cells than pyramidal cells, right?
Yeah.
Yeah, so the fact, like, so in your previous slide when you're showing how much was activated, so that's taking into account the difference in the numbers of cells and slash, so therefore axons. So
yeah. Oh, sorry. If I go back a little, indeed, it's a good question. The proportion of different axons might be indeed have an effect on the total stimulation. In this case, yeah, we took each type of axon in the number of axons equal. Okay. Indeed, this might give a bit of a not completely correct interpretation of the different types of axons activated.
Okay.
Axons activated. Yeah.
Thanks.
Okay. Yeah. So once we know, or once we found out that the basket cells might be the axons, the type of axons that are mostly involved in a clinical effect, then of course you can set up any configuration that could focus on these type of axons mostly. So in this case, we didn't do a lot of very exotic configurations or tested those configurations. So we tested anodal, cathodal, and bipolar stimulation. And as you can see, that especially in the cathodal and bipolar configurations, we could quite easily activate the basket axons. So yeah, this was motor cortex stimulation. This research has been done almost 10 years ago, and it was related to a project in which we actually were looking at optimization, deep brain stimulation by hopefully targeting the motor area in the SDN. So in recent years, we haven't been working on motor cortex stimulation anymore. And to be honest, I'm not that up to date on the use of motor cortex stimulation in Parkinson's disease at this time. But still, I think, yeah, it's quite interesting to look into the effectiveness, especially also since it's, of course, part of the total loop, and especially cortex stimulation could be quite a more non-invasive compared to deep brain stimulation. So it might very well be a very good method for a large group of patients if it works really well. Okay, switching to STN, deep brain stimulation. We have tested different leads in looking into the selectiveness of stimulation. Also, this study was done quite a number of years ago. And at that time, there was a company, Sapiens. It was set up in the Netherlands. And the main aim of this company was to look into optimization of deep brain stimulation, also the development of surgical tools to assist the surgeons during the surgery to see the local effects of stimulation, like shown here, more or less. And they also developed a new type of electrode consisting of multiple small contacts in comparison to the more conventional Medtronic type electrode consisting of the 4 cylinders that are used for stimulation. And the idea, of course, is to make sure that the field could be steered in a specific direction so that you can avoid activating elements that cause side effects. We tested this Sapiens electrode. By the way, Sapiens is taken over by Medtronic, and Medtronic did not continue with this Sapiens electrode, but instead, well, I guess you know the different types of electrodes that are used currently. So the Boston Scientific is also one of the steering electrodes that we have implemented as well in this modeling study, but I will only focus on the modeling of the Sapiens electrode. So what we did is we made use of a volume conduction model that was developed by the group of Cameron McIntyre. This model is quite complex, especially more complex as compared to the motor cortex stimulation model that I showed previously. It includes the STN, but also some of the surrounding structures, so DPI fibers, IC fibers, and also the GPI itself. And it also includes more detailed properties or the properties of conductance of these different types of tissues. So anisotropic properties were also included. So it's in anatomical sense also more realistic compared to the motor cortex stimulation model. So it's a 3-dimensional model of the STN geometry. In addition, we have a multi-compartment neuron and axon model for the different types of neural populations to test based on the potential field that's calculated then in the finite element model to see if those fibers or those cells are activated using the different configurations of stimulation. So the main focus was to see if with this new type of electrode, selectivity could be increased. And especially if the lead position is not that optimal, then still is this new type of electrode better able to steer the field away from those structures that we would not like to activate. So we use different types of positions for the electrode and moved it a bit toward the IC fiber of which we think those fibers should not be activated. So the criteria for testing this selectivity was to look at the amount of STN cells that were activating. So we would like to maximize the amount of activated STN cells, even though probably that's not that realistic if we would like to focus on the motor area, for example. But yeah, it's a very relative study, of course. So we just compare the different settings with respect to these criteria. So no activation of IC fibers should occur. and it is allowed then to activate the GPI fibers. So these are the leads that we have tested. So the conventional Medtronic lead with the 4 cylindrical contacts, and also the Sapiens lead. And of course, if you have multiple contacts that you can use for stimulation, then you have a lot of options to select these contacts for stimulation. So in this case, we only looked at 3 different combinations. One is a total ring of contacts selected to just see if by using this ring configuration, we could create the same effects as compared to the Medtronic electrode. And we use 2 different configurations for the steering modes. So a diamond shape and a star shape configuration. So this is a graph showing the results. On the left, you see the differences between two configurations. So in the upper graph, you see the Medtronic type of electrode. All the white colored cells and fibers are stimulated with this setting. And in the lower graph, you see the same for the Sapiens electrode for just one setting of the stimulation configuration. The bars in the graph show the differences between the activation of the number of cells, so in percentages. So in the leftmost bar, that's the result from the conventional Medtronic electrode. The 2 bars to the right of the most left bar mimic this cylindrical electrode. In one case, it's completely similar, or the height is completely similar to the Medtronic cylinder. And in the second bar, it's then optimized. So once you have multiple contacts, you can also have a smaller difference in changing the height of this cylinder. So it can, in some cases, be a bit more optimal compared to the Medtronic cylinder in that case. So the most 2 left bars are related to the star and the diamond configurations, and you can quite clearly see that selectivity is increased by using such a steering type of electrode. And you see 3 groups of bars. So on the left, you see the most optimal setting of the lead position, so in the center of the SDM, and the other 2 are off center. With the most right bars indicating the position quite close to the IC fibers, so the worst case position, you could say.
Just a quick question.
Yes.
Do you know what happened with the Sapiens lead? Did any patients ever get implanted with them? And do you know why they were dropped by Medtronic basically, or?
Yeah, well, as you can see in this slide, 8 patients were tested in total with this lead, but only during the surgery. So it has not been implanted. And there were quite some difficulties, especially also because of the number of electrodes that could be used for stimulation. So technologically, they were not completely identical. So the impedances were not identical for all of the contacts. So that makes it a bit or it's quite unsure then if you do make use of the different contacts, if steering is indeed as you expect it to be. But also, the number of contacts, it's probably just too much. So also the wiring of these contacts is quite complicated, but also, the selection of the different configurations is quite difficult to do.
Mm-hmm. Yeah, that makes sense. I guess screening a patient and finding optimal contacts or parameters with 4 contacts is complicated enough, but having...
Well, indeed, you already have quite a lot of options to test. So
makes sense. Thank you.
Yeah, you're welcome. So in this slide, you see on the left, the 2 different modes. So the cylindrical mode is when the conventional Medtronic electrode is used. So it's always, in every direction, it's the same. If you look at the therapeutic window, so once, side effects start to occur, that's then the limit of your therapeutic window. So it's the difference between creating the beneficial effects and the side effects. So when you can make use of steering, you can see that this therapeutic window is increased if you can steer the field in a specific direction. So we were really interested to see which type of neuronal elements were then activated in these different steering modes, especially since we do think that the IC should not be activated because that's resulting in the side effects. But as you can see here, this is one of the patient's data used for modeling. So we made use of the anatomical structures to create a quite patient-specific volume conduction model and looked at the different elements that we're activating for the different settings of the stimulation. So these currents that are indicated are the thresholds at which the side effects start to occur. And as you can see already, quite a number of IC fibers can still be activated before even the side effects start to occur, quite dependent on the different directions of stimulation. Okay, I will now continue with our neuronal network modeling. Am I still in time? Okay. So first, I will focus on modeling bradykinesia. And in this case, we looked at elbow flexion and extension. So we know in Parkinson's disease, especially the execution of complex movements. So activating multiple muscles or activating or dual tasking is more complicated for Parkinson's patients. And proposed mechanisms, it could be related to the activation, continuous activation of the resources or making use of the resources of dopamine, but also the different other types of neurotransmitters in the brain. It may also have to do with the switching, but also the selection of the actions to be performed. So basal ganglia is also involved in action selection, so making sure that the right actions are selected and all unwanted movements are suppressed. So we just focused on elbow flexion extension, and we were interested to look into the mechanisms in the brain related to the increased difficulty in performing this not that complex movement. But still, it's if you record those movements, you can see that the difference between healthy subjects and patients, as shown here. So this is the velocity measured during the performance of elbow flexion and extension, and you can see that it takes a bit more time for the patient to perform this movement compared to a control, and also amplitude. The velocity is decreased a little. So we implemented the basal ganglia and looked at the firing rates within each nucleus. We have included the different properties of the network as best as we could based on human data or when not available on animal data. We included lateral inhibition at the striatal level, so modeling then or simulating functional segregation, so this action selection mechanism. We included the different connection strengths based on physiological data or anatomical data, and we have also included neurotransmitter dynamics. So in the Parkinson's disease state, we included this dopamine depletion, and it also was related to the different pathways. So the indirect and direct pathway were directly influenced by this decrease in dopamine. So in a normal, healthy simulation, dopamine was set at 1, so a normal level of dopamine present. And in the Parkinson condition, in this case, we used a dopamine level of 0.8, and that directly reduced or increased the neurotransmitter levels in the different pathways. So that's already creating then the imbalance between the two pathways as shown before. So it's a mean field model. We represent the activity of the different nuclei by their mean firing rates. and they are representing a population of the neurons. So this is the basal ganglia scheme that we implemented, and these are the equations used to describe the mean firing rates of the different neural populations. So just to give an example, for the GPI activity, it means that there's a factor included, which is a passive decay rate of the neural activity. The GPI is excited by STN, so this is the excitatory input into the mean firing rate. Also included is the time delay because of the pathway between GPI and STN. There's an inhibitory input from striatum, and then also the different neurotransmitter levels are included in this term. And also there's an inhibitory input from the GPE. Yeah, so the numbers 10 for STN, 500 for the striatum, that's based on what we know from the different connectivity strengths. So the number of pathway fibers.
Excuse me, can I ask you a question?
Yeah, sure.
From previous slide. What is N here? I missed that part maybe.
Yeah, the N in the upper equation just indicates that it could be any type of nucleus. So it could be straight, GPE, and so on. So in the lower equation, it's that's the equation that's used for the GPI activity. And the N in that equation is related to the neurotransmitter levels.
And another question, W, is it constant through all this trace of simulation, or it's changing?
Sorry, what was your...
the W of excitatory and inhibitory, is it constant through the simulation, or you're updating it?
Yeah, it's updated, and it's related to the activity that we want to perform. So the cortical input coming from so there's a cortical input into the striatum related to the movement that we want to perform. I will continue with the. I'll come back to that. Okay.
Yeah. Thank you. Thank you.
Yes, so we have implemented all the nuclei, or the small populations of each of the nuclei in terms of its their mean firing rates. We also have included a wide system module, which translates the neuronal activity into a movement. So it generates a movement trajectory to more or less represent the actual movement. So it consists of two factors: a target position factor, which is the actual target that we would like to reach with this movement. And there's the present position factor, and that's continuously updated. So the difference between the two in the end should become 0. So then the complete movement has been performed. So we implemented two parallel modules to be able to include this functional segregation. So each module is then responsible for one part of the movement, so either flexion or extension. And this is then how we implemented the inputs. So the two modules, the first module is responsible for elbow flexion. It will then receive first an input from the cortex, and the target position is then a 90-degree flexion. So for both the Parkinson's case and the control case, it's the same input. But for the second module, we have a different input, because here we assume that there is a loss of functional segregation. So the striatum also in the second module receives some of the cortical input because of this loss of functional segregation, while in the normal situation, this second module, so responsible for the extension part of the movement, does not receive any input. So the target factor for the second phase in this case is 0, so no action. So this is only simulating elbow flexion. So this is then the activity that we see in the GPI neurons. So this is the first module in which you would expect to see the disinhibition of the thalamus, so making or allowing the movement to be performed. So the red line indicates the normal situation, the black line indicates the Parkinson's situation. And in the second module, you can see that in the normal situation, there's an inhibition. So yeah, this is the action selection mechanism of the basal ganglia, more or less. So the part that should not become active is inhibited. While in the Parkinson's condition, we see that this inhibition is reduced. So there's a reduced facilitation of the desired movement, and there's a reduced suppression of the unwanted movement. So this is the velocity pattern that we then create with this fight module. So translating the neuronal activity into an angular velocity profile. So you can already see that in a normal situation, amplitude is a bit higher, so the absolute value of the velocity is a bit higher compared to the Parkinson's condition, and it takes a bit longer for the Parkinson's condition to complete this movement. I hope the question has been answered with this.
Yes, thank you.
Yeah, okay.
Yeah, thank you.
Yeah, so we have set the dopamine at a level of 0.8. If we even further reduce the level of dopamine, then we see that the complete movement was stopped. So this could, well, maybe linked to some sort of freezing. So if we looked at the complete elbow flexion extension movement, then again in module 1, the input is given for module 1 during the first phase. Again, for the Parkinson's condition, it's now a bit longer because the complete movement has to be performed first to initiate the second part of the movement. And again, there's a loss of functional segregation then during the second part of the movement. So that's indicated here as a cortical input. So then in module 2, the elbow extension, it's more or less the mirrored image from the first module. So there's a loss of functional segregation during the first part of the movement in the Parkinson's condition. And this is not the case for the normal healthy condition. So in both cases, there's a 90-degree flexion or extension movement. So these are the complete overviews of GPI activity, and it's quite similar to only the flexion part, of course, as shown in the previous slides. But it's the difficulty is increasing once you see that especially the neurotransmitter levels have decreased because of the first part of the movement, the first phase. Yeah, so we see elbow flexion, the abnormal activity in the second module leads to an excessive depletion, and that also results then in that the elbow extension is already at a different phase compared to the normal starting position. So that the neurotransmitter levels have not yet reached the normal levels at the start of the second phase. So we have, this was also not a modeling study that we continued in this way. Of course, we are still really interested in bradykinesia and especially also the mechanisms of freezing. So this was quite a short study also in measuring the activity in just a small group of healthy controls and patients. But from these measurements, we could indeed identify that especially if you look at the EMG recordings, that Parkinson's patients do not have this distinction so much between the different phases of the movement. So in the graph on the right lower part of the slide, you see the EMG of the oh, I see it's shifted. Yeah, on the left, it's the healthy subject. On the right, it's the Parkinson's subject. So in the Parkinson's case, you see that EMG is present for both parts of the movement, while in the healthy control subject, yeah, you see quite clearly the differences between the flexion and the extension. Then also with this model, we were interested in looking into the mechanisms of deep brain stimulation. So this is totally based then on the mean firing rates, but actually every component in the equations can be adjusted and it can be linked somehow to deep brain stimulation possible mechanisms. I will not go into the details. I only will show one of the examples in which we did find quite a good comparison when we have set a weight factor for deep brain stimulation that could simulate the synaptic failure of SDN efferent projections. So in effect, the SDN input is reduced in when deep brain stimulation is applied. If this was the mechanism of functioning. So if you look then at the GPI activity, then we can see that the control situation, the normal healthy situation is in green, and the DBS situation is in black, compared to the Parkinson's condition, which is in red. So during the flexion phase, in applying the brain stimulation, the more or less similar pattern could be generated compared to the normal healthy condition. Okay, I will then continue with the neuronal network modeling that we do by using conductance-based models. So in that case, we really include all the dynamics of neurons, or as we will see later, we will simplify these dynamics by reducing also the dimensions of these equations. So if you really want to look into the membrane and include all the dynamics of each of the ion channels, then we need a lot of differential equations. So in this case, this is the equation used to model the behavior of an SDN cell. So it includes 13 differential equations. So it's quite computationally inefficient if you want to include such neurons into a network. But it's quite interesting. We have done some studies on just a single SDN neurons. The main thing, of course, is to include those aspects or those behavioral properties of a single cell in equations.
Ciska, just quickly, I just realized Bill asked a question about the mean field model in the chat, so I'll just quickly ask it. He just said, I was wondering if the model also predicts dyskinesia when direct pathway is hyperactive in indirect, underactive. Maybe Bill can ask the question. I'm not sure I quite,
Yeah, sorry, I didn't really want to interrupt the talk because you're.
No, that's okay.
But the model is great, and it is assuming the properties of the rate model, the classic rate model, and the mechanisms. And I was just wondering if it functioned in the classic rate model. It also predicted that when the pathways go in the other direction against Parkinson, it would also explain dyskinesia. So, and I was just wondering if your model, you had those pathways changing, if it would predict faster movements in the dyskinesia instead of just bradykinesia.
Yeah, that's an interesting question. We haven't tested it, but indeed, well, we can of course just give it a different input, and also increase or decrease different strengths in those pathways. So indeed, it's very interesting indeed to take a look at that. We haven't done it, but I can imagine that difficult to implement. Yeah.
Sure, it'd be interesting to see that it would predict that as well. That'd be great. Okay, thank you.
Yeah,
thank you very much.
yeah, it would be a good way to validate our modeling, of course, as well. So yeah, it should work in a different way, yeah, or indeed to resemble hyperkinesia as well.
Okay, great. Thank you very much.
Yeah, you're welcome. Yeah, so we looked into the STM neuron model, and one of the aspects that probably is quite important in relation to Parkinson's disease is the ability to show bursting activity. So yeah, the calcium type of currents, yeah, ion channel dynamics are probably responsible, or yeah, in this model are responsible for this generation of bursting. So what we see is then if an inhibiting input, so a hyperpolarization is applied to this membrane of the STM cell, then and this hyperpolarization is released, then the STM cell starts to fire a burst. So we also tested just a single cell to look at the brain stimulation. So what does it mean if you apply an additional stimulus at different frequencies? Can you then indeed yeah, overrule this bursting activity more or less? So in this case, a 50 Hertz stimulation is applied. So in combination again with this inhibiting input, just to see if this burst still occurs when the inhibition is released. And yeah, when 50 Hertz the brain stimulation, or yeah, 50 Hertz activation is applied, then indeed still this STM neuron is able to start this bursting activity. But if you look at the graph shown here, this is at 130 Hertz deep brain stimulation, and now it almost seems that this inhibition doesn't even occur. So it's completely insensitive to this inhibition. So yeah, this could be, of course, related to the beneficial effects of the brain stimulation, although this, of course, is only a single neuron, and it's not connected to any other structure in the brain. So it's probably not that realistic, but I think it's quite interesting. And yeah, one of the questions in previous studies, not only in our group, but also other groups have looked at it. What mechanism is responsible, or maybe which loop is responsible for generating tremor oscillations? And one of the proposals was that the loop of GPE and STM could be the loop that could generate these oscillations. So in both cells, if this bursting activity occurs, it can, they both then increase this bursting activity as an oscillatory function in this loop. But from more recent studies, we found, or it's very probable that it's not this GPE STM loop that's creating the tremor. But it also involves different connections in the brain. So if we look at tremor, it's quite different, of course, from the akinetic symptoms of Parkinson's disease, and it's also not correlating that well with the progression of the disease and also the severity of the other symptoms. And also, if we looked at the therapeutic mechanisms, it's probably quite responding quite differently to both medication and also deep brain stimulation. And an interesting aspect, of course, is that the tremor can be reduced by using stimulation in the thalamus, which is actually not connected. That part of the thalamus is not connected to the basal ganglia. So this is a new hypothesis, or the most recent hypothesis on Parkinson's disease tremor. At the Toronto Western Hospital, studies have been done on this hypothesis. Quite interesting studies in which the hypothesis is that it's the thalamus in which the tremor activity is generated, and it could be the basal ganglia that switches it on, more or less. So it's only the trigger to activate this tremor activity, and it could be that the cerebellum is also involved in modulating the tremor amplitudes. So we were interested in this hypothesis, and we have quite recently set up a modeling study on this by focusing on the thalamus and including those three different parts of the thalamus. So the thalamic reticular nucleus, the ventrolateral anterior nucleus, and also the ventrolateral posterior nucleus, which is also called the VIN, in which deep brain stimulation can be applied. So the aim of this study was to investigate the role of this thalamic circuit in generating Parkinsonian tremor oscillatory activity. And so, yeah, we were looking at the effect of dopamine reduction. So the modulatory effect of dopamine on these different inhibitory connections. So in this scheme, you see the different connections that we have implemented. So there's an excitation from both parts of the VL to the TRN, and there's an inhibition from the TRN back to those parts, and also there's the lateral inhibition within the TRN part of the thalamus. So instead of including the complete dynamic or the complete dynamics of all the ion channels of a neuron, we made use of the integrate and fire or burst neuron model. So that's a simplification of the neuron, but still having the ability to show the particular characteristics of firing. So regular firing or irregular firing, but also being able to generate bursting patterns. So we expect then to see that the tremor is occurring in the VLP part of the thalamus. And also we have tested or simulated what the effect of the brain stimulation could be by activating these VLP neurons. So this is the architecture of the model. All the nuclei, the part of the nucleus, were modeled using 500 of these model neurons. The TRN is split up in two, so 250 cells were included related to the two parts of the VL part of the nucleus. So this is the connection scheme. The VLA and the VLP project to the whole TRN with a probability of 15%. And then the TRN is divided in those two regions and projecting either to one of the two parts of the VL with a probability of 15%. And then there's the lateral reticular inhibition. With 80% of the other TRN neurons, but avoiding 3% of the closest neighbors. So this data or these connections are all, well, most realistically, we hope, as compared to what we found in literature. And all of the connections are then indicated by different connectivity, conductances of the connectivities. So there's then an input from GPI also to test if this GPI could function as a trigger of the tremor generation. So each cell, although we have not included real cells, we only included the patterns of GPI cells, but each cell is then projecting to 5 of the VLA cells. So either it could be a non-pathological input, so quite irregular firing, which was represented by a Poisson point process. So around 40 spikes per second were generated. And in the pathological condition, so the Parkinson's condition, also based on literature, there's an inclusion of 2 different oscillatory patterns. And so both at 5 Hertz, so tremor frequency, and also within the beta band of 16 Hertz in this case. And in the end, we also tested then the brain stimulation by applying an additional input of 130 Hertz to the VLP only, or to both the VLP but also part of the TRN neurons. So yeah, we had to set the connection strengths, and we started with a normal condition, which means that all the inhibitory connections were represented by a 6 microsiemens per square centimeter conductance. And yeah, the different dopamine modulations were simulated for values between 0.6 and 12 for the TRN inhibition, and it was varied between 1.4 and 12 for the TRN VL connections. So yeah, we have probabilities for these connections. So we did 10 trials of 10 seconds for each condition. So in each trial, a different configuration was used based on the same probability of connections. So just to give an impression of the results. So here you see the variation for the TRN inhibitory connection, and it starts with the largest value. So by decreasing this value, you can see that the oscillatory pattern starts to occur. So with a decrease of the inhibitory connections between the TRN cells, we could generate an oscillatory pattern within both the TRN and the VLP. And a similar result was found if we looked at the conductance for the TRN VL connections, also starting at the largest value, so 12 in this case, and decreasing this value. With decreasing this value, you can see that also in this case, the oscillatory pattern starts to occur. So these are very separate simulations for the two different conductivities in the different pathways. Of course, it can be a combination of using different combinations of values, but still being able to generate this oscillatory behavior in the thalamus, the TRN and the VLP.
I just had a quick question, if that's okay. I was just wondering, so the model is really interesting. I didn't know dopamine was regulating TRN so much in the lateral connections, but isn't this sort of suggesting now that this thalamic circuit is capable of intrinsically generating the rhythm? Or you have the GPI input, but is the GPI input a rhythmic input, as you know, the results of or the Hemlake results from imaging suggest that the activity started in GPI? Is that a oscillatory trigger, or is that just a tonic activity trigger?
No.
This network sort of suggests that all the oscillations can be intrinsic to the thalamus.
Yeah, indeed, that can be the case. So it doesn't need any input. Once these settings are such that it starts to oscillate, it doesn't require any input in addition. And in this slide, I'm indeed showing that the GPI could indeed trigger this oscillatory pattern. So it starts irregular input, and then when it switches to a Parkinsonian input, then you can see that patterns start to occur. So in this case, when it switches back to the irregular input from GPI, then also in this case, the oscillatory activity is reduced. But in this case, you can see that it really acts as a trigger. So the irregular input is switched to the Parkinsonian input in GPI that switches on this oscillatory pattern in the thalamus. But that keeps on going, even though the GPI input is switched back to the irregular input.
Okay.
It's quite preliminary data or results from this modeling study, but and of course, quite a number of connections are not included. So as you can see, the VLA is almost silent, which is probably not the case. But that's maybe also related to the connections missing. So there's no cortical loop included. And also the basal ganglia are not included in this model. So, but it does show that indeed GPI could switch on or trigger the tremor activity in the thalamus.
And I guess also the spinal loop, the sensory feedback can be important to modulate tremor to a certain extent. So
indeed.
Very nice, very nice. Cool, thank you.
Yeah, thanks. Okay, I'm almost at the end of my presentation. So yeah, in conclusion, yeah, the oscillatory activity can be generated in these connections within the thalamus. And yeah, the frequency of oscillations in the VLP, it doesn't have to be related to the oscillatory input. And that's also what we do find in clinical results or measurements from GPI. Sometimes GPI, of course, is correlated to tremor activity, but it doesn't have to be the case, or it's only intermittent. But that's probably related to the loops that we have not included in this model. So yeah, to test deep brain stimulation, in this case, yeah, deep brain stimulation is switched on at the time t is 5 seconds. And yeah, in this case, we yeah, include both the VLP and the TRN for being influenced by deep brain stimulation. So when amplitude of deep brain stimulation is increased a little, then we can see that yeah, this oscillatory pattern is reduced. And if we sum all the synaptic currents, then we have some sort of representation of the local field potentials, and those local field potentials quite nicely show the result of deep brain stimulation. So in this case, at time t is 5 seconds, deep brain stimulation is switched on, and you can see that the tremor activity is reduced. Yeah, it is of course still a matter of validating this model using clinical or yeah, even the recordings from brain nuclei to test indeed yeah, the validity of these effects that we see in a model. Yeah, one example, if we look at the combination of using yeah, VLP and TRN for stimulation, then we see that yeah, the reduction of tremor power increases with increasing the amplitude of stimulation, which is actually what we also see in clinical practice. If we only include the VLP for stimulation, then it has the opposite effect. So increasing the amplitude of stimulation yeah, reduces the effectiveness. So in that sense, it might be yeah, more or it could be possible that it's not just the VLP that's activated by yeah, VIM stimulation, but it's also part of the TRN that's influenced by stimulation. Okay, very shortly, I think time's almost up. Some future studies, yeah, we will continue with this, yeah, continue both the modeling in volume conduction models, but also the neural network modeling. We're now working together with the group of Cameron McIntyre, which used to be Cleveland, but it's now Duke University. But they have a data set of patients in which yeah, EMG and accelerometer data is collected during a resting condition, but also during different UPD rest tasks, while yeah, the Boston Scientific directional lead is used for stimulation, and all different contacts are used for monopolar stimulation, and yeah, amplitude of stimulation is increased. So it's quite an interesting data set to look at yeah, the effects of stimulation and steering of the field in relation to the different symptoms. So we're working with them together to yeah, hopefully find out more about the different yeah, tissue compartments or yeah, different neuronal structures that we need to activate to get beneficial effects, and the ones that we should avoid in activating. Yeah, we're looking into action selection mechanisms or yeah, response inhibition mechanisms, also in relation to freezing. So cognitive aspects play a role in Parkinson's disease as well, and especially also in freezing of gait. So the different situations may be involved in generating freezing of gait. So in this case, this is a data set from Professor Richardson. I'm still working on it, and hopefully it will result in a paper. So this is a go, no-go task. So a go means the patient has to press a button. A no-go means that no action should be taken. And this is a recording done during surgery. So this is inside the SDN showing the activity increasing in relation to a go response. And yeah, quite recently, we also have included a go, no-go task into our modeling. So quite similar to the previous model on tremor, we included in this case then the basal ganglia, but also we'll look into the go, no-go mechanisms in basal ganglia activity. Yeah, we're also focusing on freezing of gait and also the effects of cueing. So this is also a recording done at the Toronto Western Hospital in collaboration with the group of Professor Richardson. In this case, finger tapping is the task to be performed by the patients, and they have to synchronize their finger tapping to a rhythm that's applied using a metronome signal. So using different frequencies also for this metronome to see if they can indeed still synchronize their movements with this pattern. And also in this case, SDN activity has been recorded. So in the lower graphs, you see the power spectral densities of the local field potentials recorded from the SDN. And especially in the left graph, which is one of the Parkinson's patients included so far, this patient could quite well follow the metronome signal in finger tapping. And you can quite nicely see that the peaks, the powers is related to the frequency of the finger movements. And on the right side, this was a patient showing quite severe tremor during the task. So this tremor activity is completely overruling almost all other activity. So this is my presentation. I thank you very much for your attention. Would really like to visit you again someday, but maybe next year will be an option again. Thanks.
Thank you very much, Ciska. That was an excellent talk. A lot of great work. I kind of echo Bill's comments that the full basic ganglia models during different motor activity and DBS, those simulations are very exciting, and I'd love to talk to you further sort of about that and implementing our recent findings, test hypotheses further.
Sounds good.
Yeah, we can open the field to some questions. We got about 7 minutes until the official time is up. I think we can sort of stick around if anybody has, wants to discuss more detail, but no obligation. But if anybody has questions, please feel free. All right, no questions. I was very curious to see, you went over it very quickly, but the mean field model, you said you implemented several different sort of DBS hypotheses and found that I think reduced SCN efferent output basically correlates best with healthy state. But can you go back to that slide? Like, I was very curious to see sort of the other hypotheses. And oh, sorry, there's a hand up. Maybe you and I can speak about it at some point.
Yeah, it's fine. It's fine.
Let's ask where's the hand up? Okay, go ahead, Alexandra. If you have a question, you can turn your mic on or you can type it, up to you.
Excuse me, that was a mistake. I meant to applaud. Excuse me.
Okay, perfect. All right. Okay, so maybe we go back. to my questions. There we are. So I'm kind of curious, you know, there's this whole controversy of like, what is the what is the mechanism? Is it like somatic neuronal inhibition? Is it efferent excitation? Is it antidromic hyperdirect pathway excitation? Were you able to look at like, you know, the involvement of hyperdirect pathway in here and whether it's necessary for beneficial effects?
Yeah. Actually, we can of course include every pathway in the DBS mechanism. These were the 7 ones that we tested using the parameters so far. But indeed, we can look into more aspects even. But it's then more related to the direct inhibition or direct excitation of STN if you look at the hyperdirect pathway. Yet I've shown only one that indeed creates quite similar results to the normal situation. There's another one, I'm not really sure which one it was. And actually this might not be that a plausible effect, this partial synaptic failure, since it's also shown that it might be a differential effect that we see in deep brain stimulation if you look at this, the neuron itself and the efferent effects. So it could, well, it's maybe more probable that the efferents are indeed active instead of underactive related to the brain stimulation. In our model, you can of course model each parameter in a different way and relating it to maybe stimulation. But this is something we still need to find out how valid each of these different hypotheses are also in the translation in our model.
Yeah, I mean, this does coincide with some of the hypotheses of how it works. You know, there could be local suppression of neuronal activity, but each of the DBS pulses should activate the efferent. But then there's also, I think, mostly theoretical evidence that at a high frequency, even the axonal action potentials could fail over time. So very interesting.
Yeah.
Question from Francis: is there a publication for this for the main field model? And I too am curious about that.
Yeah. This model has been published. It's included in the slides. It's the Moroni paper. I'm not sure you can still see it. But if you're interested, I can of course send you the paper.
Yeah, that would be great. Okay, perfect. And then as well, your later neural. Francis, do you want to ask a question yourself?
Yeah, sure. I just was wondering about, you know, the conductance-based model you showed, and when you put the DBS in at different frequencies, you didn't see, and I just was, do you know which slide I'm talking about? It was the single cell model that you had when you applied DBS. Yeah, exactly. Yeah. So I just wanted to clarify my understanding. So on the right-hand side, where you have the inhibitor input, so in both cases, inhibitor input has been applied. Yeah. Okay.
Yeah.
So the lower case where you have the 130 hertz and you don't see, basically, you know, it's just too fast. So just the sort of what's going on there potentially is that this excitation is just is there just sodium inactivation, or that it can't? Yeah. Do you have some sense of why you don't see that the effect of that inhibitory input when you have the high DBS?
It's probably related to the more slower dynamics of the calcium currents. So they can keep up with the 130 hertz rhythm of the deep brain stimulation, while the sodium currents can still continue firing in this.
So basically, so right. So therefore, the mechanism, like this sort of this bursting can't terminate essentially, the firing. Yeah. Okay. All right. Yeah. No, I was just trying to understand. And sorry, for your later model that you talked about towards the end, your neural network model, is there publication for that also, or in the works?
No, not yet. We're working
Okay. All right. Okay. Great. Thank you for the lovely talk.
Yeah, thanks.
Well, I think if there are no more questions, we can conclude the session. Thank you very much again, Ciska, for the great talk. I look forward to chatting with you further about this stuff.
Yeah, you're welcome. And yeah, thanks again for the invitation. It was nice meeting you again.
Wonderful. Thank you.
Thanks a lot for great talk, Sister. And
Thanks.
yeah, I hope you make it back here. We should have more regular Zooms as well. We have some interesting data I can send if you're interested in sort of the cognitive aspects. We're looking at some of these cholinergic border cells during the rhythmic tapping task. But now, you know, we did some of the finger tapping. I think you have that data, but we also switched now to doing the alternate pedaling, right? And
Nice.
we have some really interesting with the you know, cholinergic border cells, these ones, and they quite clearly switch into like a burst mode during the rhythmic pedaling, and then they go back during the rest in between those different frequencies. They just go back to their sort of regular mode. So they're doing this kind of pattern shift. You know, you probably look at the overall rate is probably changing as well, but there's a clear shift. But the dynamics of the burst is quite different. It's opposite to the one you're showing in this current slide that you have up here. That's like an STN with the ordinal ISIs are sort of are increasing as they go along from left to right. And the structure of these in the cholinergic, it must be a different channel, are actually opposite. They start wide and then they finish quite high. So I think it's a different kind of calcium channel. So, but yeah, so I'll send you a picture of it. It's quite interesting. We're also, when we're doing these, we've been doing some oddball stuff as well on the cholinergic neurons, and even sometimes when the patient doesn't get the task to sort of count out those tones they're supposed to be paying selective attention to, they at the end of the task, there's also bursting. So I'd probably have enough data with some of these border cells if you're interested in you know, the role of cognition and freezing. I think there's some interesting single cell stuff that could you know, go along or be looked into, especially, you know, if you have some modeling of the burst dynamics would be cool.
Yeah, really interesting. Yeah, I'm really interested. Yeah.
So yeah.
Yeah, we should talk more often again.
Yeah. So I'm actually just waiting for a case to start now in Colombia. So hopefully I'll see if I can get some more cells tested, but it's a long time since we did the go no go, but we can still try to do something with that data. Would be great.
I'm still working on it, and I still would like to write a publication on it. But I will start after the summer again.
Great. Okay. Well, thanks again for doing the talk. There's lots of interesting stuff going on. So
yeah.
He's quite busy.
Yeah, thanks. Yeah.
All right. Well, good luck with everything. I'm gonna carry on with the case in Colombia.
Yeah, it was nice to see you again.
Okay. Bye.
Bye.
Thanks again, Ciska. I just wanted to say again, thanks for the accepting the invitation. It was awesome talk. I'll send you an email. I have a million things on my plate at the moment, but I'm very interested in those like full basal ganglia models. And I had written out a question to ask you about like, can we like manipulate activity based on various hypotheses of TBS to see, you know, to validate which mechanisms may or may not be involved. But it seems you answered it. So I'm looking forward to taking a peek at that paper. I wasn't aware of it. So
yeah.
Really cool stuff.
Yeah, let me know if you I can send you some of the papers that I mentioned today.
Yeah, I can. I'm sure I'll find it. I have means of, but if I
Yeah,
don't
it's-
find anything, I'll let you know,
Right.
and I'll certainly
Sure.
bug you in the near future.
Yeah, sounds good.
Okay.
Yeah, thanks for the invitation. It's nice
Yeah, of
to see
course.
you. And
You too. Okay. Ciao. Have a good day.
ciao. Yeah, same to you. Bye.